it's already difficult to talk about sex for lots of people. And then if you have a difficulty and the healthcare system doesn't seem to know how to help you, that's going to bring up a lot of fear and anxiety. A study of midlife Canadians found about 40% of women have sexual difficulties. So these are not rare. There is a really big known orgasm gap where cis men have orgasms 75% of the time, cis women have orgasms 30% of the time.
Is there a definition of an orgasm?
How do you tell someone that you're not interested in having sex?
Would you mind taking a moment to first define what the difference between arousal and desire are?
When does difficulty reaching an orgasm become something that's maybe worth seeking for help?
Vulva Squad, welcome back to another episode of the Vulvalution. We're going to start off a little bit differently today. We heard from some of our viewers that you're absolutely loving the content, but you want to know a little bit more about us. So we were thinking it could be fun to start off each episode sharing something from this week or since the last episode that we learned about women's health or that we're applying in our life from a past episode. So Mathilde, please take us away.
Okay. So from one of our last episodes, we learned that it's okay to sit on a toilet bowl. And I never did it in my life. And I think a lot of Quebec people who's watching this podcast, I think it's a big thing in Quebec that no one ever sit on a toilet bowl. But I recently started to try it out because I know it's good for your pelvic floor and it's like you're not putting as much.
You're so brave.
Pressure. Yeah, so I'm trying it at work and it's okay. The toilet is clean, it looks clean, no problem. But I still can't do it in like bars, restaurants. It just looks so disgusting to me. And this weekend I went skiing and I had my ski boots and I looked at the toilet bowl. Looks disgusting. There's like pee on it. So I'm like, for sure not sitting on it. And so I started squatting, but I had my ski boots and I just couldn't really squat enough. And so I just fell on the toilet bowl.
So Mother Nature said sit down.
Yeah. So that was disgusting. But I just reminded myself that, you can't get any disease from it. It's okay.
Fantastic.
Yeah. Okay. What about you, Sabrina?
Okay. My update for the Vulva Squad is that last week I had a UTI that progressed to a kidney infection. Never had a UTI before. It wasn't really that bad. I didn't really know what was going on. So this is just a PSA that if you're having weird urinary symptoms, get checked out. And I actually did. I was trying to be proactive about it, but kidney infections, they suck. They really take you out and they can be quite dangerous. So my advice, if you are peeing a lot, more than normal, go see your doctor ASAP.
Okay, so now we can introduce the podcast of today.
It was awesome. I think everyone's going to love this episode.
Yeah, so cool to have a therapist, like a registered psychologist, to talk about sexual disorders. So yes, it's a thing. We don't talk about it enough, I think.
So we don't want to spoil anything, but you're going to love this. Let's get into it.
Yay. Hello, Vulva Squad. Today we're diving into a very interesting and sometimes taboo subject about women's sexual health and dysfunction. We are lucky enough to be joined today by Dr. Katrina Bouchard. So thank you.
Thank you for having me.
Dr. Bouchard is a registered psychologist and assistant professor in the Department of Obstetrics and Gynecology at the University of British Columbia. She also works in women's sexual health and couples therapy, and her research and clinical work focus on the emotional and relationship sides of sexual well-being, especially with people living with chronic vulvar conditions and other sexual health concerns. She practices at the BC Centre for Vulvar Health, where she works with patients and their partners to provide evidence-based and multidisciplinary care.
So welcome to the Vulvalution, Dr. Bouchard. Thank you so much for joining us today.
Thank you. Happy to be here.
All right, let's get right into it.
Okay, so first we want to ask you if you could tell us a little bit about your path into clinical psychology and also what led you into the focus of specifically women's sexual health.
Yeah, so I've wanted to be a psychologist for as long as I can remember, which is a bit interesting because there aren't psychologists in my family, and for a long time I didn't really know where I got the idea from. But a few years ago, I actually saw a career book that my mom had got me, and psychologist was in it. And so I think that's where I got the idea. So long before going to undergrad, I had this in mind, and then when I went to Queen's for my undergrad, I took, typical psychology courses like Intro to Clinical Psych, and my professor was a sex researcher. And when she did the module on sexuality, I knew right away, this is what I want to do because I found it so fascinating. And so then from there, Queen's has a really good presence of sex researchers in Canada. So it was really easy for me to get involved in research and kind of go along that way. And clinical psychology, I think, blends a really nice mix of more of the science-based work research and then clinical practice, which really appealed to me.
Wow. Interesting route. Okay, one thing that you shared with us when you taught us in class last semester was that there's not really one sexual health discipline, and instead people end up in psychology or medicine, and then they have to sort of seek out their own sexual health training. How do you think that affects people who have sexual health issues in accessing care?
I think it plays a big role. It's sort of like women's health in some ways, where sexuality can be viewed as a niche topic, even though it affects so many individuals and couples in the world. So I find there's a number of factors that are affected. One is prolonged wait time for patients to get timely diagnosis and accurate diagnosis and appropriate care. So it slows down the process. We know from some genital pain research that on average people are seeing 6 doctors before they get an appropriate diagnosis. This study is a little bit older, and I'm hoping that improves over time, but it's very onerous. And so if people are having sexual difficulties, it's taboo to talk about. Healthcare providers aren't necessarily always informed. That can lead to hopelessness and feeling helpless, which then kind of perpetuates the issue, right? So I think that the world is shifting and there's more focus on sexuality, and particularly I think UBC does a really great job of training different clinicians. So I'm very hopeful that this will improve.
Wow. Yeah, good to know that it's changing and people don't have to go through 6 different doctors before actually receiving good care.
It's much too long.
Yeah. Okay. So what is the psychology, health, and sexuality, your phase lab that you have? What is it about? What kind of questions do you answer in your lab?
Yeah, so the Phase Lab is a group of researchers in different backgrounds. So some folks are from psychology, but also biology, medicine, women's health, other social sciences. And so we are an interdisciplinary group of researchers, myself, graduate students, undergrads, medical students, gynecology residents. And so our focus really is on sexuality with vulvar health as well, and then looking at these issues from a psychological lens, being that my background is in clinical psychology. So we have a few different streams of research. One aspect is sexual arousal research, which was really a focus of my PhD. So bringing people into the lab, showing them erotic materials, and measuring their sexual arousal. I'm really interested in looking at that from more of a health lens. So for folks who have vulvar health concerns, looking at arousal in different populations of people. We also do a lot of dyadic research, and so that's where we bring both members of a couple into a study. They independently answer questions about their relationship and different factors, and then we can analyze them as a unit to see how people impact each other. So that gets more into the dynamic. And then another part that I'm really excited about is treatment studies. So right now we're running a clinical trial of a new couple-based sex therapy for low desire. So that was the focus of my postdoc with Natalie Rosen at Dalhousie, and now we're testing it in a larger sample, and that's funded by CIHR. So really looking to do more treatment research as we go along.
Very interesting. Good questions you're asking and topics.
Thank you.
So we're going to talk a lot about sexual health and sexual dysfunction throughout this podcast. And I wanted to ask you why you think it's so taboo to talk about such topics in our society right now.
So I think there's a lot of different factors, sociocultural factors around messaging that people receive about sexuality. And so whether that's coming from home, receiving negative messages, or simply no messages and sort of implicitly learning, okay, this isn't something we talk about. And then sometimes when folks go to school, they don't get great education. I also think that that's improving, thankfully. So if you don't talk about sex at home, you don't talk about it in school, then you get into a relationship and you don't really have the skills to talk about it, or sexual interactions outside of a relationship. So I think from a kind of social learning perspective, that if you don't get modeling of how to talk about these things, it can feel like a steep hill to climb once you are wanting to have sex with other people. And then the other aspect as well is that sex can bring up a lot of emotions. And so if people are having sexual concerns, for example, it's already difficult to talk about sex for lots of people. And then if you have a difficulty and people don't seem like the healthcare system doesn't seem to know how to help you, that's going to bring up a lot of fear and anxiety and maybe some shame as well. And we know that when the brain is flooded with all kinds of emotions, then it is more difficult to communicate or broach topics. So I think it's multifaceted for sure.
Yeah, there's certainly a lot of layers to why people feel like shame around talking about it. But you know what? We're here today to break that stigma.
Yes, I love that.
Yes. Yeah, and I feel like if you can't relate to anyone, if you don't talk about it with your friends, your family, you think maybe that you're like different, you're weird, you feel bad about it, so you don't want to talk.
Absolutely.
How common is it for women to struggle with sexual dysfunction? Is it very common?
It's very common for people to have sexual difficulties. So there's been a long-standing sexual health type survey in Britain called NATSAL, and it's been going on for multiple decades. And so when they look at representative samples from, age 16 to about 75, I think, they see that about 50% of women report having a sexual difficulty in the past year. Once they look at how many of those people are distressed by it, it goes down quite a bit to more around 10%. So more transient sexual difficulties are very common. So are sexual dysfunctions. And then a study of midlife Canadians found about 40% of women by midlife, so 40s and beyond, have sexual difficulties. So these are not rare concerns whatsoever, rarely talked about, but very, very common.
Okay, you mentioned there a couple times sexual difficulties and then sexual dysfunction. Would you mind just explaining for our viewers what is the difference between that?
Totally. Yeah, so sexual dysfunction is a little bit more of a clinical term. It's a way to communicate around like clusters of symptoms that fall into certain disorders, if you will. I know that sometimes it's a bit hard on the ears to talk about dysfunction and disorder. It can feel a little bit judgmental to some people, and that's totally fine. I like to use sexual concerns or difficulties as well. But really what it comes down to when we're thinking about sort of like, let's say, the clinical definition of sexual dysfunction, it's a cluster of different symptoms together that are persistent. So it's not transient. It's not like one day you have low desire, oh, that's a sexual dysfunction. So it's usually 6 months of consistent, persistent difficulties. And the other really important part is that the person needs to be distressed or bothered by them. So it's not the job of a clinician to say, oh, that's a disorder or that's a dysfunction, because sexuality, has a lot of variability. And it's not meant to be a judgmental perspective, more so that if people come to us and say, this really bothers me and it's been going on for, 6 months or more and it's pretty consistent, then we can have a look and do an assessment and see if one of the categories of sexual dysfunctions fits. whereas sexual difficulties can be more broad. It can be that, more transient or not really meeting the specific cluster or consistently, or maybe it's not as distressing. So that's one part. The other part is sometimes when we're diagnosing sexual dysfunctions, there's certain criteria. And so if your difficulties are better explained by a medical condition, for example, then sometimes that kind of precludes you from fitting the kind of category. So they can both have their place and their purpose.
Okay, thank you for clarifying.
Yeah. And from our little research, we saw that there's 3 main categories of dysfunction. Do you want to mention the 3 of them?
Yeah, sure. So in the Diagnostic and Statistical Manual, so the DSM, this is a tool that mostly psychiatrists and psychologists use, but others as well. And it's quite a North American tool. There are other tools as well. It's not the only one. Mm-hmm. But there are 3 categories. One has to do with arousal and desire. The other one has to do with orgasm, and the third one has to do with genital pelvic pain.
So we're thinking we could get into each of those for a couple more questions. So
sure.
Starting with female sexual arousal or interest in arousal disorder, would you mind taking a moment to first define what the difference between arousal and desire are and how they're related, but how they're also different?
Absolutely. Yeah, happy to do that. So this is such a good question because I find that people often aren't quite as aware, or they have kind of their own conceptualization of what these things mean.
Well, even for myself in your course, I didn't realize what the difference were until you went through and explained how you could have one without the other and vice versa. So I think this is so interesting. Sorry.
Yeah, no, I love it. I love the enthusiasm. So what I'll say is let's start with arousal. Arousal has different components to it. So there's more of the mental component. So feeling mentally turned on, being into the sexual activity or the sexual cue that you're seeing, and kind of that elaboration. It could be around fantasy, sexual thoughts, just being into it basically mentally. And a lot of people don't realize that mental arousal piece exists because they think a lot about the physical aspect of arousal. And so basically arousal is really centered for both sexes around changes in blood flow. And it has to do with increased blood flow to the genitals and other areas of the body, which makes them more full, more firm. In people with vulvas, it produces lubrication with that change in blood flow. So it's really the physical, but also the mental changes. And then with respect to desire, this is more of a motivational state or an interest in sex. So if you see a sexual cue, like a really good looking person, maybe you're going to kind of get into it, have that mental arousal, and you're going to feel desire to pursue that person. Also, people often think that desire needs to be step one in a sexual situation. So you sort of feel like, oh, I want to have sex, let me pursue that. But it can also emerge from a sexual situation. So maybe you have a small amount of interest or desire, and then it really grows throughout a sexual interaction. And what's interesting is we make this distinction between arousal and desire. So one being more physical, mental changes, desire being more motivational. But when research was done, quite a bit of research was done, they found that women found it more difficult to distinguish between desire and arousal than men. And so often women thought, desire and arousal were kind of intertwined, whereas men more so thought about arousal as erections and desire as something distinct.
That's so interesting. Kind of makes sense because there's not like an obvious, erection happening for most women. Yeah. So not as obvious as a penis. And so I will note that obviously I'm talking in very gender binary terms, and that's not the reality of the human experience. It's a lot more nuanced, and a lot of the research that was done in the past was very ciscentric and heterocentric, so I just want to give that caveat. But yeah, it's really interesting to see how people conceptualize these things differently, and at a group level women tend to see more connection between arousal and desire from the research. Very interesting.
Yeah. Wow. And when people talk about libido, is that a synonym of arousal or more desire?
Yeah, great question. Libido is usually used interchangeably with desire.
Okay.
So I've noticed in my field of psychology and sex research, we really focus on the term desire or sexual interest. Sometimes libido is used more so in certain medical contexts and also by the public. I would say lots of people use the term libido. Libido is a bit more expansive, so it has a long history, kind of going back to Freud and talking about like the sexual drive, this sort of like sexual energy, and it's more theoretically expansive. And we've kind of moved away in research from libido and tried to operationalize desire a little bit more.
Okay, so now that we have a good understanding of the difference between arousal and desire, can we talk about what happens when they're not aligned with each other and what that experience can be like for people?
Yeah, so I think there's lots of different situations where people can have different experiences around, like maybe they're feeling mentally turned on, but not necessarily physically turned on. Or sometimes, again, going off that assumption I was mentioning of like step one is desire. Sometimes people feel like they need to kind of like wait for desire to emerge, but really flipping it where people enter into sexual activity that they're interested in, but they might not be feeling super, super high desire, then that is where desire can emerge. So there's been quite a bit of research on this idea of sexual concordance, so the alignment between mental and physical arousal. And generally what's been looked at is the emphasis has been on sex and gender differences. So women are less aligned than men, and a lot has been made of that. So it's an interesting area. I have my own sort of like pet projects around this from back in my master's, where we showed that when you measure blood flow in the vulva versus inside the vagina, that women do have a lot of alignment with like mental and physical arousal. And so part of it might be that, you know, different sexes experience sexual arousal in slightly different ways based off of anatomy. But I think that there's like a very wide range of normal, perfectly fine sexuality and not needing to worry too much about the alignment unless people are really distressed by it.
Okay.
So what is female sexual interest / arousal disorder?
Yeah, so that's where we really see how interest and arousal are brought together in this category, whereas before they used to be distinct. So there was a desire disorder and an arousal disorder for female people, and now they are together. They're not necessarily merged exactly, but a new category came out, which is female sexual interest arousal disorder, over 10 years ago now. And what it consists of is, again, a persistent, consistent, more than 6 months or more distressing concern with desire and or arousal. So what that looks like is, you know, someone might not feel interested in sex. If a person, like a partner, approaches them, like kind of initiate sexual activity, they might not be very receptive to it. They're not really into it. Or when they do have sexual activity, they don't feel as much pleasure or excitement as they used to. So there can be a large picture of different representations of SIAD because people need to meet like 3 categories out of 6. So it can look a lot of different ways for different people. But I would say what's really, really important is that it's not about pathologizing people for like, oh, your desire fluctuations are bad and disordered. Again, we always have to remember it's about the distress and about the persistence. So it's actually very common, normal, healthy for sexual desire to ebb and flow. That is not a disorder. But when it keeps going and people are really bothered by it, then we can do an assessment and try to understand.
So the difference between how someone might know it's just a sexual difficulty or a problem tied to a certain time is how long it lasts for and how distressing it is for them. Okay.
Yeah. So the other thing is like we want it to be persistent. So most of the time, more days than not, things like that.
Okay.
We don't want to overly kind of pathologize normal variation. So a good example is, you know, often in the postpartum period, people experience lower desire. Well, that makes a lot of sense.
Yeah.
Your body has gone through a massive change, hormonal fluctuations, role change. change, relationship change, you have to take care of a human, all of these things. It makes sense that when you're doing this, big change in your life, that desire changes. It's not a disorder.
Right.
Whereas if it persists like long past the point of postpartum and persists for years and years and never really comes back, then that could be something that someone's really bothered by and they want help for.
Right.
And if someone never had sexual desire or arousal, could that be, if they're distressed by it, could be a disorder too? Or
It's a good question, because we know that some people are asexual. So lifelong or very long-standing lack of interest in sexuality, and this is a whole other domain of human experience. And what the research really suggests is asexuality is a sexual orientation. So just like someone might be interested in women or female people or male people or multiple different gender sexes, asexuality is sort of in that group as well. So it just takes careful assessment to try to tease out lifelong low desire. Perhaps that could be part of asexuality. And someone could be distressed by having a lack of desire, even if they are asexual, because there's a lot of messaging around
societal pressure that you would
Yes.
feel like something is wrong with me, even
Yes.
if you're not actually necessarily feeling distressed by it.
And so it takes a skilled clinician to tease those apart, and then to try to work with the client or the person to really align with their experience, and perhaps like they want to accept themselves as asexual and work through some of the difficulties, sort of like a minority stress situation where there's lots of social and cultural expectations around that all humans are sexual, which is, it's not the case.
Right. Very interesting. Okay, so this is kind of a big question, and I know you're not going to be able to get into the weeds with it, but generally, how do clinicians go about treating someone who's struggling with sexual interest or arousal disorder?
Yeah, it's a good question. And so some research has been done on a pharmacological approach. So there's different medications that can be used to treat low desire. I'm not a physician, so I don't prescribe these medications. I'm just speaking about research here. Generally, what has come of those is that they haven't led to the most effective treatment where people are really pursuing these medications in the same way that Viagra was like a blockbuster drug. And so those medications, there's an injection, there's a pill, haven't taken off in the same way. And that seems to be that they're not as effective as they might have hoped. That being said, drugs and different treatments are always being developed and tried in different ways. But what we do know from meta-analyses, so groups of studies analyzed all together, is that psychological therapy does make moderate to large changes in sexual arousal and desire concerns. And so generally, sex therapy is the approach, the kind of umbrella term. And sometimes people are like, oh, sex therapy, that sounds really interesting. And so it is, but not as much as you might think. So it's really similar to other types of psychological therapy where we're using different structures like cognitive behavioral therapy or mindfulness-based therapy to treat sexual issues. So it's definitely not, a sexual surrogacy situation, although there are people who provide that service. Sex therapy is a form of talk therapy. It can be done with individuals, it can be done with couples, in groups. So the treatment for myself that I tend to focus on and that we're developing and testing is couple-based sex therapy for low desire. So we know that from research, low desire is the sexual dysfunction that perhaps is the most affected by interpersonal factors, relationship factors.
I guess that makes sense. It's a very back and forth. Are you interested? Am I interested? And then you get that reaction from other people too.
Yeah, so it's a dynamic process. And so because of lots of research at this point showing that the dyad or the people having sex influence each other, a couple-based approach we think makes a lot of sense. So what it might look like in practice is working on kind of basic stuff. So working on communication, expressing needs to each other, talking openly about sexuality. You would maybe be surprised about how many couples don't talk to their partner about concerns. It's never been discussed until they come to the therapy room. So looking at sexual interests, managing how to decline sexual activity if your partner initiates in a way that's supportive of well-being, trying different activities at home, something called sensate focus, which is a touching exercise. There's really all sorts of things looking at that perspective. And then, as both of you know, Dr. Laurie Brotto, who's really championed mindfulness-based treatment for sexual dysfunction, she and many others use a mindfulness-based approach to address low sexual desire. And that's going to be more centered on mindfulness meditation in different ways and also providing education.
Very interesting. So lots of different ways you can sort of approach helping people with this issue.
Yes.
Struggle.
Yeah.
Absolutely.
So I want to ask for our listeners, and I think it's going to help a lot of people, how do you tell someone that you're not interested in having sex? Like how, I know it can be, for some people, it might feel like you don't want to hurt the other person's feelings, and you kind of want to not force yourself, but you're just going to do it even if you don't feel any desire.
Yeah, that's a great question. Really, really important one. A very common issue with people in partnerships and relationships where you might not be particularly interested in sexual activity in a given moment because maybe you're going through stress, you're not feeling well, you're just not really feeling it in the same way. You know, people have lots of different reasons. And so there is research on sexual rejection, which again sounds a bit intense, but it's really about managing that conversation in relationships. And the way that the research suggests and our treatment also approaches is to be a little bit more direct, but in a kind way. So don't try to avoid the problem or pretend you're sleeping or do sort of these avoidant type of approaches. It can be really helpful to just let the person know how you're feeling, but with warmth. So, you might say, I have a really important work deadline that's coming up on Monday, and I'm feeling kind of stressed about it, so I'm not feeling super into having sex right now, but I just want you to know that I really care about you, I really like having sex with you, some type of validation or recognition, and with kindness and warmth, reassurance. So, could we check back in on Monday after my deadline is done and take it from there? So what's really important is that warmth, validating or providing that reassurance, being direct and explaining what the reason is, and then also giving a time to follow up. Because what can happen is people say no, not right now, or no, and then the partner can, without information, they can think oh, I guess I'm not attractive, or they don't like having sex with me. The mind can kind of run wild, as our minds do.
Yeah.
And so giving a more straightforward answer of the reason, and then also giving a timeline, because otherwise the partner might think okay, when can I ask again? Or is this going to happen? A lot of things can come up. So just trying to be direct and providing a bit of a timeline, knowing that it's not like a contract to have sex on Monday. It's more of a let's touch in and try to be responsive to each other's needs.
I really like that. I like those. You outlined 3 actionable things people can do. When you said that to me, I felt love it, not rejection.
Good.
So I think that those are great steps people can take away.
Yeah, and I guess sometimes the reason can just be I'm not feeling it.
Yeah.
And let's recheck tomorrow or
Totally.
But love you.
yeah.
And then you can also have other types of affection. So maybe someone doesn't want to have sexual activity, but you can still cuddle, you can still hold hands, you can kiss, you can hug. There's a lot of ways to show affection. It doesn't have to just be sexual, which sounds very obvious. You would be surprised what can happen in long-term relationships where the only way people are showing affection to each other is during sexual activity. And that really misses out on a lot of the benefits of affection in relationships.
Yeah, wow. Okay, let's move on to the next type of sexual dysfunction, which is female orgasmic disorder. Starting off this, I feel like an important question to talk about is what actually is an orgasm? Because I feel like a lot of people, maybe experience orgasms differently than other people, or they don't even know if they've had an orgasm, especially when you're first at your sexual awakening or whatever.
Yeah.
So is there a definition of an orgasm?
Yeah. So I think a lot of us probably think about orgasm in terms of what we see in like movies, the
Right.
big O moment where people are, like loudly expressing themselves, making a lot of noise. It's like this definitive peak. And orgasms can be that way, but they don't have to be. And so I really like this question. So an orgasm really is a really high level of excitement and pleasure, sometimes a peak. And then it resolves afterwards. So it's like a building of pleasure, excitement, tension in a moment or moments that resolve and kind of return to baseline, and there's a release of that tension. So people can also experience rhythmic contraction. So this is like the lower part of the vagina contracting in the case of a assigned female person. And so it's that combination. It's high pleasure and excitement, tension that resolves. Some people experience orgasm as like a very distinct peak. Other people might experience sort of like lower levels of like repeated intense pleasure. Some people have multiple orgasms. So there's not a one size fits all. And sometimes people can be so focused on the goal of orgasm or quote like achieving orgasm that they miss all of the pleasure that leads up to that point. So that's an important piece to keep in mind too.
Okay, so they're diverse is the answer.
Yeah.
Okay, good. I think that's important to clarify so people can enjoy what they're enjoying, I guess.
Yeah, and people can feel different sensations.
Yeah.
They're not going to be the same every time.
Yeah, orgasms can vary in intensity within a person as well.
And when does difficulty reaching an orgasm become something that's maybe worth seeking for help?
So one thing that's really important when considering orgasm difficulties is around education and different types of sexual activity. So sometimes people are trying to have, let's say we have like a cisgender male-female couple and they're having sexual like insertion, so penis inserting into a vagina, and that's really the focus of sexual activity. So there's no external stimulation of the clitoris. There's no variety in sexual activity, maybe oral sex or manual touching. It's really, really focused on penile vaginal sex. For a lot of people, that does not trigger an orgasm. And in fact, it's not really the most common way that women tend to experience orgasm.
I remember when I learned this for the first time, I was like mind blown. I was like, why have TVs and movies always shown this in a way that like that is how people orgasm? And I was like, that's just not true. And then you talk to your friends and you're like, well, that's really not true.
Yeah, definitely. And so that's the representation we see of sex, right? Which is like a very thin slice and a certain perspective on like rip each other's clothes off, insert a penis, instant orgasms, lots of yelling. This is a very like, not representative, let alone like queer people or diversity. So it's a very thin slice of representation of sexuality and not really representative of reality. The oral sex can be a really important part for people with vulvas to have intense sexual pleasure. Using vibrators, very important part. So external stimulation to the clitoris is really, really important. And so remind me of your question, though.
When does difficulty reaching an orgasm becomes maybe something worth seeking for help?
Right. Yes. So again, it's that persistence and the distress that's important. What we wouldn't want to do is kind of pathologize like, oh, you have an orgasm disorder, if the type of stimulation that would typically trigger an orgasm isn't happening. So there is a really big known orgasm gap where, cis men and women having sex, cis men have orgasms 75% of the time, cis women have orgasms 30% of the time. And sometimes it can be thought of in the vein of women's health of women are just more complicated, or they're less sexual, or they're more difficult or complicated. But the truth is that both of these groups of people, so both males and females, have the same type of orgasm capacity, but the type of approaches differ in terms of what might be needed on a group level.
Very interesting. Okay, so how common is female orgasmic disorder?
Yeah, so orgasm difficulties are common and they can be challenging for younger people, like you were alluding to. So if we look at different population studies, there's a wide range, 10 to up to 30% have orgasm difficulties. That rate is always going to go down when it comes to having like the persistence, the distress, all of these things we've been talking about. But it's not rare, just like other sexual dysfunctions.
Now, how would your approach treatment for this disorder would be like?
Yeah, female orgasmic disorder is a really interesting and I think fun concern to treat. Can be really, satisfying for the clinician, but definitely for the patient. And so basically what a lot of sex therapy involves is providing education. So talking about what I was mentioning before about different types of sexual activities that trigger orgasm, different tools that people can use. It would involve doing a thorough assessment before starting and figuring out, does the person have certain beliefs about the way orgasm is supposed to happen or beliefs about the behaviors. And then what's most commonly used is training at home, so not in the office, of masturbation. So using different tools and solo sex and kind of learning to practice behaviors that are intensely arousing and exciting to trigger that sort of peak level of arousal. So it's a mix of education, breaking down barriers that are getting in the way, and then practice. And typically, like I said, when people resolve this issue, they tend to be very satisfied and happy about it, which is nice.
Yeah. I feel like some people feel shame of like practicing, or they feel weird to practice by themselves, and they don't really they're not comfortable maybe with their body and like how they're feeling. Very,
very common. Very common to have shame around solo sex, to think of it as secondary to partnered sex, to think of it as like, you only do that if you need to. But it is such an important part of sexuality if people are open to it. Some people are not due to certain, religious beliefs or different factors. So it's not a one size fits all by any means. But if people are open to it even a little bit, then exploring, it's really hard to tell another person what you like sexually if you don't know what you like. And one of the effective ways of figuring that out is to try things on your own.
I think it's so interesting that it's sort of just a norm and people just assume that young boys start masturbating, but there's no talk about that when it comes to women or females or just people with vulvas. It's just kind of like taboo, and then it's not normalized in the same way. So how can we expect that when we have sex for the first time, we would whatsoever know what to expect or what we would like?
Definitely. There's a lot of taboo around it. There's a lot of myths as well. So sometimes people will think like, oh, if I do use a vibrator, then I'm going to get desensitized and I'll never be able to have sexual activity without it. That there will be nerve damage. The small vibrators that are used sexually are not going to cause that. And in terms of like sort of getting addicted or being stuck with always having to use a vibrator, this is not borne out in the evidence. So it's myth.
So we don't have to be as scared of vibrators.
No.
Good.
No.
And I don't think it's true, but it's like a big thing about vibrators. People are using it too much, decreases your feelings when you're having sex with a partner. So to have a more intense orgasm during the penetration sex with your partner, to not use any vibrators like a week or 2 weeks before. So then you would have more pleasure.
I see. Yes. I don't think that has been shown in terms of research evidence. For humans get used to whatever type of stimulation that they like tend to prefer, in terms of like, if people have solo sex in a certain way. So a really good example with people with penises is using like a very firm grip, which is sometimes called in sex research and therapy as like a death grip. So if someone always has solo sex in that consistent way with a very firm grip, and they find that really satisfying and they get used to it and they practice it, then it can be difficult. Maybe there's going to be delayed orgasm once they're having a different type of stimulation. But these are things that can be altered. It's not a situation where, okay, you've used a vibrator and now you're stuck with that and you can never change what you want to do. But if it's pursuit of pleasure that people are looking for, which is the case most of the time, we know vibrators do help with pleasure. They are important, and most of all, clitoral stimulation is very important.
Okay. Well, that was a great talk about orgasms. We should do that more often. We're going to move on to genital pelvic pain and penetration disorder. So, first of all, what is it?
It's a mouthful.
Yeah.
I'll say.
Yeah.
So I usually call it GPPD. So a genital pelvic pain penetration disorder is, again, like a cluster of different symptoms around pain and fear of penetration. So people might have difficulty with vaginal insertion. They might have pain. They could have a fear of vaginal insertion, and then they could have like really pronounced muscle tension in the pelvic floor muscles, so the bowl of muscles that holds all your pelvic organs in. Yeah, so it can manifest in different ways and have sort of different presentations, but really it's around pain, fear, tension, and difficulties with insertion.
And many people experience pain sometimes during sex because of the position, or I'm guessing it can be normal in some situation, but what if it becomes like every time you're having penetration it hurts? When do you know you have to see someone?
This is a very important topic. And so, yes, people can experience discomfort with sexual activity, like a position, or it can vary based on cycle because the position of the cervix changes. So if people feel sort of like something rubbing against their cervix, it could be uncomfortable. Some people like that. But yes, discomfort can happen. I would say that pain, like if we think about a scale from 0, no pain, to 10, the worst pain imaginable, we usually think about like a 4 out of 10 and above as something that could be potentially needing some help. So if there's like low level discomfort, like a 1 or a 2, and it's transient, it just happens sometimes. If you add lube or change positions, it goes away and it's not every time, then that might just be, you know, being flexible in different situations. Whereas if you're having like a high level of pain, like a 7 out of 10, and it happens repeatedly, then that could be a sign that you need some help. And that would be a case to talk to your family doctor, because there are lots of different reasons that people could have pain at the vulva. So it could be an infection, it could be an injury, it could be a whole host of things. Hormonal, that's a really common one. And so I would say like the amount of pain, the duration, the persistence would be important things to look at.
Okay, and I think when we talk about pain with sex in general, a lot of the time it's sort of minimized or misdiagnosed for women or people with vulvas. Why do you think that is?
So many reasons. I think it's really interesting because we do have quite a bit of research on vulvar pain. Not as much as something like depression, but we have quite a bit of research. But I think this is a really good example of where we have like a knowledge to action gap, where we have like 3 decades of research on vulvar pain, a multitude of labs dedicating their time to studying this condition, but it's not always trickling down to the frontline healthcare providers. And so, if something is like rarely discussed, a physician doesn't receive training or any clinician doesn't receive training, then it can be difficult to get appropriate care. And like I said, there's different ways to have pain. It can be like hormone, in which case usually a doctor will be able to see that the vulvar tissue looks different, looks atrophied, and that can be treated with hormones. Or if there is like a positive swab for yeast, then that can be treated. Or there's a different infection, the things that can be measured or observed, then people can get more appropriate treatment, hopefully. But with something like vulvodynia, which is idiopathic vulvar pain, so not so much explained vulvar pain, it can be difficult because there's not something that's directly observable or measurable. And so, if there's not sort of a medical test for something, it can be more difficult to get the care that you need. And it's multifactorial. So you might have a hormonal component, you might have a muscle component. Yeah, so I think that clinicians want to do a good job and they do care about patients, and sometimes they just don't have the information they need or the knowledge they need, and it can be difficult if you're working from a knowledge deficit to really help.
Yeah.
I think it's more of a systems issue.
Yeah, almost like we were talking about at the beginning, how there's no formal sexual health field or discipline, and that everyone's coming at it with these different angles. That means there's no formal education for people within the medical system. So it's not really it's not their fault, you might say, that they don't know explicitly how to deal with these struggles. But it'd be nice if we could solve it at a system level.
Especially because vulvar pain is so common. So any type of like discomfort or vulvar issues, like 1 in 5 people with vulvas are going to go to their doctor. Things like yeast are a very, very common reason that people go to see their family physician. 10% or more of reproductively aged women have persistent or consistent vulvar pain. Again, these are not rare problems. And so I do think that I understand at like an individual level that people want to do a good job. I think we need to push at a systems level, and there are wonderful people doing this in BC in particular to really push for change at a system level.
Good. We hope to see that.
Yeah. Yes.
And from a psychologist point of view, what would be the treatment for this disorder? Is it different from the other ones or similar?
It's similar in a lot of ways. Sometimes people wonder, like, why is a psychologist working in vulvar health? That makes no sense. And it can be a little bit of a tricky situation to navigate, because what we don't want is for people to think like, oh, I'm seeing a psychologist, they think the pain is all in my head. And that's a common concern. So the idea that if, you have pain and your doctor's like, go see the psychologist, that you're making it up. And that couldn't be further from the truth. We know that pain is real. It is a real sensory and emotional experience that people have. And psychologists are involved in all sorts of chronic pain treatment. And also, the other example I like to think about, I have a really good friend who works in spinal cord injury, and she's a psychologist. We don't ever say like, oh, a spinal cord injury, that's in your head. We have the recognition psychologists have a role in play in health conditions, even if they have a physical cause or a, biopsychosocial cause. So the treatment involves, again, a really careful assessment to see what is going on for that particular person. And even if there is like a specific cause of pain, like let's say an injury to the vulvar area or some type of like physical cause, after that physical cause heals, the pain can persist. And that's where a lot of thoughts and emotions around the pain experience, which are totally understandable. No human likes to be in pain unless it's like their choice and they're using it in a way that they do find enjoyable. But, pain that's not in your control, humans don't like that. And that's how we're wired. So the treatment really is about looking at thoughts and emotions and reactions that people have to pain and trying to help them walk out of the cycle where they're having really like negative and catastrophic thoughts. So they feel really scared of the pain. So they avoid all sorts of things that could trigger the pain, like sex or even undressing in front of their partner to make sure sex doesn't happen. And then they feel disconnected and sad. That makes the pain worse. So that's the fear avoidance model of chronic pain. And so a psychologist would work with the person to try to help them break down that cycle. And just a small example of how that would happen is doing pain diaries. So noticing, like rating the intensity of the pain, the qualities of it, how intense, and then also what happened before, during, and after in terms of thoughts, emotions, behaviors, working on it that way. So it's a very CBT approach. I also use mindfulness-based therapy. Again, Laurie has led a lot of that work. And CBT and mindfulness are both effective for treating genitopelvic pain. And we do see improvements. And that doesn't mean the pain is in the person's head.
Right. Yeah. I think that's such an important point to be making, is that we're not telling you're crazy at all. Your pain is real, but sometimes talking about it and coming at it from a psychological approach can help.
Yeah, it reminds me of my IBS problems, and I had to see a psychologist for it, and I had no idea because they did all of the medical tests and everything looked fine, and then it was like related a lot to stress and anxiety.
Yes.
And it felt good to see a therapist because she knew that it was not all in my head. Like, it was real pain, but we could find ways to release a little bit of that pain.
Totally. And I think a lot of the times, because, you know, in certain conditions that we research that are less researched in sexuality, I often look at like IBD and IBS research because it's much more, it's further along in terms of like amount of research, journals, things like that. And I think that's like a really, really good example of how psychological principles can help people get out of pain or out of symptoms, even like they're real, but it still helps. Yeah.
Okay. Fantastic. I think we're going to move on from the sexual dysfunctions to talking about couples and interpersonal dynamics, which is another big part of your research, dyadic research. Starting off, why do you think it's important to consider a couple rather than just an individual when you're treating sexual dysfunction?
I think it can be tremendously helpful because a lot of the times people want to have sex with another person, particularly if they're in a relationship. And individual and couple therapy are both really helpful. So is group therapy. So I don't want to say like pit them against each other, but where I think couple therapy is helpful is, you know, if a couple isn't talking about their sexual difficulties at all, it can be extremely helpful to have them both come into a room. They have like a third person there who's very knowledgeable about sexuality, can answer questions, and it just creates like a forum for them to talk. Whereas if I'm seeing a person individually, then the onus is on them to go home and talk to their partner and be like, okay, this is my home practice. This is what we're talking about in therapy. And that can be a high bar to clear for some people. Some people do a great job and are perfectly comfortable, but others aren't. The other thing is when we talk to one person in a couple, we're viewing the issues through their lens necessarily. Whereas when there's a couple in the room, we can hear both perspectives. The couple can come to a common understanding of the issue. A big part of couple therapy is to try to take away the hyper focus on one person. So if you have SIAD, you have low desire, that can often feel like, oh, I'm the problem, I'm the low desire one, I'm the deficient one. Whereas we often reframe, or typically reframe, of like, this is a couple issue, that the two of you want to have sex with each other. There's dynamics within your relationship that impact this. So instead of the onus being on one person, it's shared in the couple, and that can be really helpful. Yeah.
That's a beautiful way to look at it, because a lot of the time, like, if I would imagine if you're not wanting to have sex, there's so many other factors in your life that are contributing to that, and a lot of those come from your relationship and the things that are on you to do and the things that are on your partner to do, and just that dynamic can be quite complicated. So I think it's great getting two people in a room to actually talk about what the issues are. Are there any common or classic communication issues you see in your clinic repetitively that you might want to share?
Yeah. So not just in my clinic, but like in a lot of different sex therapy settings, just simply not talking about the sexual issue, like I mentioned before, just like having never discussed it. Imagine I like gave you a problem to solve, like some kind of a puzzle, but you weren't going to talk about it at all. It would be really hard to work together. It would be hard to know like who's working on what or how are we fitting together. So if you don't talk about it, it's very hard to solve a problem. I think as well, in the research, I see this manifested in a lot of different clinical contexts, is that there's a high level of emotionality talking about sex. So people can be very prone to being hurt, feeling guilty, feeling anxious, feeling shame. And that can derail the conversation. So I would say that's really common as well. There are people who have like quite hostile responses, like really blaming the person with low desire or pain, really being critical, being demanding. These obviously aren't very helpful to the health and well-being of the dyad. But for the most part, when I see partners and couples, partners are very supportive and really want to solve the issue, which is like very heartening to see. So I don't see a lot of like very, very high conflict in different clinical contexts. But certainly if you were to talk to more relationship therapists, so less sex therapists, I think you see a lot more conflict in folks going to therapy for their relationship rather than their sex life.
That makes sense.
Yeah.
Okay, interesting.
And if you want to openly talk about sex with your partner and it's not something that you usually do, would there be like a better time to do it? Would it be like right after having sex because you just did it, or before, or just at dinner, just a different time outside of the like intimacy time?
Love this question. So these principles come from like general communication principles of talking about tricky issues. And so a lot of this, if people want to read more about communication, there's a great book called Nonviolent Communication, which sounds like, oh, what is this? But it's really communication skills. So don't let the title deter you. What we would say, because sex can be such a vulnerable topic, we recommend don't talk to your partner about issues during sex or like right after. Plan a time in advance. We tend to communicate a bit better when we plan things out usually. Just like, you've planned out some questions to have this conversation today. You're not kind of like just going off the top of your head. I would view a new conversation about sexuality in very similar ways. It doesn't need to be super formal. Sometimes people don't like this idea of, oh, it's so stilted or robotic. It doesn't need to be super formal, but giving some forethought to it can really help you be more effective. So I would say, I would try to think about the partner of like, okay, when would be a good time to talk about something that might be a little bit tricky, might bring up some emotions. Maybe I won't talk to my partner on Friday night after they've just had like a really difficult shift at work when they're exhausted from the week. So trying to think about a time where your partner might be more receptive, rested, less stressed, and more able to receive information that might trigger some painful emotions, even unintentionally. Planning out, what do I want to say to my partner? So kind of like key messages, and writing them down for yourself, just kind of reflecting on that. And then making sure to kind of like use a little bit of a sandwich method. Did the two of you, have you learned about like the sandwich method?
It's like when you like say something nice, say something, and then say something nice again.
Yes, yeah. So trying to again be like warm and reassuring, yet direct. And so I don't think anyone wants to think like, oh, I'm bad at sex. No. That's a tricky, touchy feeling for most people, if not everyone. And so that's why we say to avoid it in the bedroom or wherever you're having sex, because the person might feel like, oh, I just did a bad job, and that feels really vulnerable. So trying to talk about like, this is how I would usually frame it, of like, our sex life is really important to me, and I want this to work well for us for a long time. And I think so that's like a bit of a gentle opening, and it's also relationship focused. It's like kind of highlighting the team aspect. And then I would say, I just hope we can talk about X, Y, or Z. This is why I want to. And again, it's just because I want us to be close and to both enjoy sex or something like that. And then afterwards or during, try to be really receptive to what your partner says, be open to it, and just try to accept that you're not going to resolve everything in one conversation. So know when to like kind of be like, okay, that's enough. Like take a small bite if you've never talked about sex before, and then reflect on what it was like and repeat.
Yeah. Okay. And I think I saw somewhere that's important, especially for confrontation, to talk about like, I think this, instead of being like, when you do this, I don't like this.
Absolutely. I think that's in nonviolent communication, if I remember correctly. So using I statements instead of blaming. Sometimes when we're emotionally activated, we do that. Like, you are like this, you do this, you're failing in these ways. And that naturally prompts defensiveness in another person. Whereas if you use I language, partners are usually better able to like hear that and reflect on it, less accusatory.
Yeah. And I think it's a good idea to just maybe, if you have a lot of points that you want to bring up, maybe divide it into
don't just show up with your list and be like, this is everything you need to do better.
Yes, absolutely.
That's what not to do.
Totally agree.
So What are like some signs or issues that might suggest that it's time for a couple to come see you or a sex therapist?
I think if the issues have been going on for a long time, it doesn't need to be years and years, but persistently going on, maybe they haven't been able to talk about it, or it's just like really tricky and they just like want some outside help, I would say. So I don't think things need to be extremely severe. Any means. People can also come for, a couple of sessions. Sometimes people just have like a particular issue that they want to talk about. Otherwise, their relationship is like very satisfying. They're able to communicate, but they just need to kind of work one issue out. They might need a couple sessions, move on. Other people might need more help. So I think it's like if you're finding yourself feeling stuck and like, oh, we can't get beyond this issue, we're just stuck. Then seeking help. Or if you're going through like a big life transition or a new medical diagnosis or something like that, you can also take like a preventative approach where you're trying to understand or a new injury, anything really that's changing your sexuality, trying to like talk to a therapist about how to adapt to new challenges can also be really helpful.
Very interesting. Yeah, I think that preventative approach is probably smart because you can go in and sort of anticipate what might come and then be able to get ahead of it.
Yeah, and I think just learning how to communicate or like learning how you're feeling and then communicating with someone, that's also important.
It's kind of like general therapy where it certainly helps people who are struggling, but it helps most people just generally to get better at understanding yourself and your partner.
Definitely.
Okay, so now we're moving to what women really want to know section. So you guys asked a few questions, and we're going to ask Katrina Bouchard here. So the first question is about ADHD. So what is known about ADHD and sex, and is there any tips for people that live with ADHD and have maybe some troubles with sex?
This is a really interesting and emerging area of focus, ADHD and sex. So a colleague of mine at UBC, Dr. Sam Dawson, they just published a paper on ADHD and sexuality. There's also a really wonderful clinician, Lynn Pichet in BC, who has a website, I think it's called ADHD and Sex. So very simple. And she has a workbook of concerns. A lot of her practice is around helping people who have ADHD around different issues, but sexuality. And I think she even has like a course coming up. So there's resources out there and there's recognition. Where ADHD and sex can collide a little bit is sexuality and like sexual response, like desire, arousal, what we've been talking about, are very contingent or can be quite contingent on attention. So directing your attention. So, it's really common in sex for people to get distracted, to think about, oh, what's for dinner? What do I have to do tomorrow? If you're like a parent, like, is that a noise that my child is making? Or if you have a dog scratching at the door, all sorts of things can distract us during sex. And in the best case scenario, we're able to redirect our focus back to what's going on, the sensations. That's why mindfulness is really helpful, because it teaches you how to do that. But for people who have more challenges with executive function, with directing their attention, more prone to distraction, then this might be, augmented in those situations. And so what can be helpful is just like learning more about ADHD and sex. A lot of sex therapy is psychoeducation, so learning about the issues. And then I think seeking out a knowledgeable clinician or like resources. So self-help books are quite plentiful in the area of sexuality, and they can be a more accessible approach for people to pursue. So that's what I would probably recommend, is to try to seek out resources around ADHD and sexuality.
Okay, we'll try to put some resources in the bio.
Yeah. Such an interesting question. I've never even thought about this, but the two are very linked. So I'm glad we had a question. Okay, and the next one is from one of our listeners. I'm a 24-year-old woman, and I've only been able to orgasm twice in my life, despite many attempts. Is that concerning?
Good question. I would want to know so much more about this situation to be able to adequately answer this question. But touching on some of the stuff we talked about before, I would want to know, like, what type of sexual activity does this involve, like, typically? So is a person trying to just have vaginal insertion with no other types of sexual stimulation? Basically, are they having the type of sexual activity that we would expect to trigger an orgasm? If they're not, then that's a change that people can make and move towards more intense pleasure, which really is what an orgasm is. Would want to know as well if, like, what was different about the 2 times that they think they had an orgasm. Was it a situation like they were on vacation? Their stress was much lower than normal. They were able to be more present and think about, really pay attention to those sexual cues. I would try to understand, like, what was different about those times? Because stress, anxiety, those can interfere with ability to trigger an orgasm. So those would be like my follow-up questions. I think that once the person could explore those things and try some different strategies at home, if the problems continue to persist, then it could be worth looking into to get help. I would say in that case, a good resource, a book called Becoming Cliterate, as in a clitoris, Becoming Cliterate.
Great name.
Yes, by Laurie Mintz, is a good book if someone is looking for help around orgasm.
Okay, we will link that one.
Okay, so now we can conclude. So if someone listens to the podcast and maybe realizes that they might have a sexual disorder or a sexual distress or have been struggling with it for months, what steps should they take now?
So in terms of people who need to seek help for sexual difficulties, I think an accessible way to start is to look into books. And so there are lots of good books on sexuality, more and more coming out. I would say look for books that are written by licensed healthcare providers. So that could be like a psychologist, a licensed marriage and family therapist, and many more types, or sex educators. So I would say a really great book to start, because it gives like a really general picture of female sexuality, is Come As You Are by Emily Nagoski. So these are really well written books that are like interesting to read, not necessarily like a dry kind of textbook read, if you will. So say for desire, there's 2 newer books that I really like. One is called Desire. It's by Fogel and Wenzel. So that's just, again, giving you more of a concentrated look at desire. The other one that I just read recently, Anatomy of Desire, by Emily Jamea. It was fantastic. A lot of these books have like case studies or like case examples woven throughout. And so it can be helpful to see examples of other people and the difficulties they've had. For orgasmic disorders or difficulties, I think Becoming Cliterate, like I said, by Laurie Mintz is good. There's also an older book called Becoming Orgasmic by Hyman. It's still available. One thing about books that are a little bit on the older side is sometimes they are very like cis-centric, so assuming like women or females or kind of heterocentric. So if that is not your vibe, then that is okay, and there are other options, which I'm happy to like send a longer list. And then for pain, there's a really great book, again, that's an overview called When Sex Hurts, and that's by Goldstein and some other colleagues. So I would say that's where I would start, mainly because sex therapy is expensive. So if you have really good benefits, you have access to psychological care through those extended health benefits, then definitely you can pursue sex therapy. There are lots of different great sex therapists that you can look into. And if that's not so accessible, then pursuing the books or a combination of both can be another really great way to go. My lab does have an Instagram called @thephase_lab, and we post about books on there. So if anyone wants to have a quick look at that, they can, just to see. And we continuously post books there and kind of highlight them.
Fantastic. Okay, that's such great resources. One question I have is, for people who would like to access sex therapy, do they need to go through their family physician and get referred to someone, or is it like a direct access to the therapist as is with other therapy?
Direct access.
Okay.
So you can self-refer to a sex therapist. So there's not that additional step. And then sex therapy itself is not like a registered health profession. It's usually psychologists or registered clinical counselors in BC, social workers, like different professions can do it. So when it comes to health benefits, you'll just want to check like if you're seeing a psychologist, how much coverage do you get for that? And then also sometimes people are a bit nervous, like, is it going to say like sex therapy in big letters and I'm going to send that to my my health benefits, and they might feel a bit shy about it. But typically it's just going to say like Katrina Bouchard, psychologist, and they're not going to know the content of the therapy because it's confidential.
Okay. Well,
Good to know.
Yeah, very good to know.
Okay, we like to wrap up all of our episodes by asking our interviewees 2 questions. These are big ones. The first one is, if you could bust one myth about women's health forever, what would it be?
This is a hard one because it's so big. I think it would be in the vein of like women not being included or women's research being underfunded, all of those challenges that we hear about that are faced in women and inclusive women's health research, is that the myth is that, you know, women are too complicated or too difficult to study, that women's health conditions don't need as much of a focus, or things like that, that really are placing kind of viewing women as overly complicated and frankly like not worth the hassle to look into. I think that have more and more evidence that when we focus on women's health, when we fund women's health research, that it benefits all of society, and that hormonal fluctuations or life transitions aren't so complicated that they can't be studied with a little bit of, you know, attention. Yeah, so I would say that would be my hope.
That's a good one.
Yes.
I completely agree.
Oh my God, yes. And thank you for doing already so much work about this. I think it's so important. Yeah.
Thank you.
And it's good to see that there's a lot of books that are written about it too. It's maybe becoming a little less taboo, and that's what we're trying to do with this podcast too. And the last question is also a really big question. What's one change you hope to see in women's health within the next 10 years?
I would like to see, like from my biased perspective, I want to see more integration of sexual health care into the public healthcare system. So BC is really amazing in terms of like having multiple hospital programs that focus on sexuality and vulvar health. But I think that's quite unusual in Canada and in North America and other places in the world. And it's quite surprising because we know that sexual health problems are so common, like we've been talking about, and they also commonly come with other health conditions. So if you have like cardiovascular issues, then you might have difficulties with blood flow that contributes to sexuality. And if you have diabetes, that can also affect blood flow. So a lot of like major health concerns that we do care a lot about in the health system come with sexual difficulties, and then sexual difficulties on their own as well. So what I would like to see is more integration and access, so that not only a select few can access sex therapy as sort of like a niche or a specialized, you know, cherry on top healthcare. I think I would like to see it more integrated as any other part of health that needs care and attention.
Yeah, it needs to stop being sort of like an afterthought that some people can access, and more like just a standard of care, because it's so important. I completely agree.
Yeah.
Love that.
Well, thank you so much
Thank
for
you.
sitting down with us today. This has been such a good episode. I think the people are going to love listening and learn a lot. So thank you so much for sitting down with us.
Thank you. Thanks for the invite. This is so fun.
That's good.
Yeah, we fucking nailed that. It's like we knew